I'd like to begin by introducing our first speaker, Dr. Neil Powe. Dr. Powe is the Chief of Medicine at the Priscilla Chan and Mark Zuckerberg San Francisco General Hospital and the Constant B. Wofsy Distinguished Professor and Vice Chair of Medicine at the University of California at San Francisco. His major interests are in improving discovery, education, and clinical practice in medicine, propelling academic organizations to function effectively and efficiently, enhancing scholarship and multidisciplinary collaboration, and developing future talent and leadership in the health professions. Dr. Powe's work unites medicine and public health with the goals of saving and improving the quality of human lives. Among the work that he's led in his career is the Choices for Healthy Outcomes in Caring for ESRD, or CHOICE study, one of the first national cohort studies of patient outcomes on dialysis. He's also a principal investigator of the CDC and CDC National CKD Surveillance System. He has over 500 publications to his credit, and he has studied the early referral of CKD patients, patient-physician contact in dialysis care, cost effectiveness of screening for proteinuria, racial differences in cardiovascular procedure use among patients with CKD, the effect of treatment modalities on survival, outcomes of emergent versus standard hemodialysis for immigrants, and the outcomes of dialysis care by type of ownership and access to transplantation. Dr. Powe is a member of the National Academy of Medicine, the American Society of Clinical Investigation, the Association of American Physicians, the American Society of Epidemiology, and he's a master of the American College of Physicians and a fellow in the American Association for the Advancement of Science. Among his honors are the Diversity Award from the Association of Professors of Medicine, the John M. Eisenberg Award for Career Achievement in Research from the Society of General Internal Medicine, the Distinguished Educator Award from the Association for Clinical Research Training, the Belding-Scribner Award from the American Society of Nephrology, the David Hume Memorial Award from the National Kidney Foundation, and the 2021 John Phillips Memorial Award for Distinguished Contributions in Clinical Medicine from the American College of Physicians. Dr. Powe recently served as co-chair of the National Kidney Foundation American Society of Nephrology Task Force on reassessing the inclusion of race in diagnosing kidney disease. And that's going to be the subject of his talk today. It's my great honor to welcome and introduce Dr. Powe, and thank you for joining us today, Dr. Powe. We look forward to your presentation.
Thank you, Dr. Silver. So I'm going to share my screen quickly. Let me just get this. So thank you for inviting me to talk about the subject that I've been immersed in actually for the last year and a half. And I would say even more than that, the last few decades, since disparities in healthcare has been an important theme of my work. As I have no financial disclosures, I just want to make it clear, though, even though I was on the NKF and ASN task force, the conclusions and opinions I expressed today are my own, and it shouldn't be construed to represent the task force, although I will include many things that the task force did. So, you know, a year and a half ago when George Floyd was murdered, as well as Breonna Taylor and Ahmaud Arbery, there was a really uprising and calls for social justice because of the structural racism in society. And that also existed and bled into medicine. And one of the first places that people took aim was at the use of race in clinical algorithms with the measurement of kidney function or estimated glomerular filtration rates as a target. And I wrote this as I was sheltered in over the July 4th holiday a year and a few months ago. I wrote this editorial over the July 4th weekend because I was very concerned. And I was very concerned because Black kidney function matters, because Black adults in the US are 3 times more likely to develop kidney failure, and on average 5 years earlier than white adults. And that's true for other ethnic minorities, Native Americans, even Asians, Hispanics, and particularly for Native Hawaiians and Pacific Islanders. Black kidney function matters because minorities are less likely to get early care from a nephrologist, as shown in this top figure. And they're also less likely to be waitlisted or receive a kidney transplant. And so the fuss about all this is that use of race in clinical algorithms, such as those for eGFR, institutionalizes racism, and its incorporation causes disparities. That was really the claim that was being made. And the fuzziness about this is that race is a social construct that does not reflect biological function. GFR is biological, therefore race should not be used to estimate it. And even this concept of race as a social construct, even though it's now been illuminated, it's been recognized by the National Academy of Medicine with this definition done in 2003, that it's a construct of human variability based on perceived differences in biology, physical appearance, and behavior, not a biologic reality. The fuzziness is also as race is difficult to obtain and ascertain, and interracial and ethnicity persons are increasing. And you can see in the recent census, the number of people filling out the census with two races tripled over 10 years to 10.2%. And the diversity index, which is a measure of if you took two people randomly from the population, whether they would be from two different races, is also increasing across the United States, but is variable by geographic location. So the question is, should race be part of patient care and clinical decision-making? Now, on social media, this was the chatter I heard that led me to write that article, that race was introduced in the measurement of kidney function to be racist, that disparities in specialist referral and transplant waitlisting were caused by putting race in the equations to estimate GFR, that there was a difference in GFR between Black and non-Black persons, that Black persons do not have different creatinine levels than whites, that investigators assign races in the studies, and that I think most importantly, as some institutions did, normalizing Black persons to the white person standard will solve the problem. So I want to submit to you that all of this is fiction and myths, and I'm going to try to illustrate that by illustrating the facts around GFR measurement from the past to now. And I'm going to show this quote that I think exemplifies the issues, that the arc of the moral universe is long, but it bends toward justice, that was made by Dr. Martin Luther King more than 50 years ago. So here are the facts. In 1976, the Krakow-Gault equation was developed in 240 white men and extrapolated to both women and to all ethnic minorities. An estimate was later put in for women. And in 1982, the disparities that I just showed you were first documented in the New England Journal of Medicine some 10 years after Medicare covered ESRD care for all Americans. And you can see that at some ages, up to 5 to 10 times more likely that Black men and Black women than their counterparts were developed ESRD. In 1988 to 1998, African American disparities in the waitlisting and nephrology referral were documented. And let me show you some of that data. On the left-hand slide is work done by Paul Eggers that demonstrated way back in 1988 through 1992 that African Americans were less likely to be waitlisted for transplantation. And on the right-hand side of the slide is work done by Craig Kinchin, an African-American fellow who worked with me some years ago on the choice study that was mentioned, that Dr. Silverswag mentioned. And what he showed is that Black females and Black males were more likely to receive a late evaluation, as shown in the slide. So this was all before 1998. Then in 1998, a sentinel study that I think many people don't know about was published in the American Journal of Kidney Disease, looking at creatinine values in Blacks and whites. And this is the data from the study. The study was done by Camille Jones, an African-American physician working at the NIDDK. And she used the NHANES study, which is a national representative sample of the United States, to show what's in this slide, that serum creatinine levels at every age were higher for Black men and Black women compared to their white counterparts. What's interesting is Camille involved her sister, Calmer Jones, who is well known actually for this allegory, Gardner's tale of racism, pointing out that what is internalized racism, personally mediated racism, and institutional racism. But what they said is this in the conclusion of the study: in the absence of information on measured GFR, it's not clear to what extent the variability by ethnicity reflects normal physiologic differences rather than the presence of kidney disease. And until this information is known, the use of a single cut point to define elevated serum creatinine values may be misleading. So that study was published 1 year before the first equation was introduced or even published in the Annals of Internal Medicine, the MDR-DEGFR equation, that used the variables of serum creatinine, age, sex, and self-reported race to estimate kidney function. And what was interesting is MDRD involved women, and this time a large number of African Americans. And they found this signal that led to introducing this coefficient of 1.21 for African Americans, raising their eGFR based on measured GFR. So this is the data that they showed. This shows serum creatinine concentration measured GFR in both men and women. And at every level of eGFR, every level of measured GFR, the serum creatinine level was higher in men and Black men and Black women than in their counterparts, something that was been replicated even till today in many studies. So the question is, was the introduction of this coefficient in the MDRD equation, was it racist or was it evidence-based precision medicine? So let's dial forward. It wasn't until 2007, after that, 8 years after the equation, that we had 50% penetration of eGFR reporting in US laboratories around the country. You can see that in the slide in the lower left-hand corner. And then in 2009, the equation was actually updated by the CKD-EPI collaboration, this time using many studies, not just one study, and it included women, Blacks, and actually a few individuals and other ethnic groups. And so this was how the study CKD-EPI equation was derived in thousands of participants, both in a development validation sample. Blacks were 31% of the derivation sample. Ethnicity, race and ethnicity was self-reported. And actually in the development data set, there were actually coefficients that were different for Asians and possibly Hispanics and Native Americans, but they were normalized to white as the reference standard because of the small numbers of individuals that were studied. And then led to the African American coefficient being revised down to 1.16. We know that these equations do not perform well in some other populations from Africa, Asia, and Brazil. And that's interesting and worthy of further study. So what we also had in 2012 is the addition of cystatin C to this CKD-EPI estimation equation, what's called the combined assay equations. And there is still because it includes creatinine, a signal for African Americans. And then in 2013, we finally reached an over 90% of penetration of eGFR reporting in US laboratories. And the standardized assessment of kidney function equations was incorporated into clinical practice guidelines some 14 years after the first estimation with race was put into equations. And you can see that even in 2019 in this slide, the MDRD equation was still the most prominent equation being used in the United States. So it takes a long time to change practice. So I know that was quick history, so I'm going to just go over some key points. One is that disparities existed before the race equations were ever introduced into the literature or into clinical practice. That equation development followed up on health statistics data and evolved to increase diversity and reflect the non-GFR determinants of serum creatinine. The third is that research standards and adoption into practice take time. And I think importantly, well, let me just tell you more about what happened. In 2017, we saw calls for race removal from eGFR reporting. And then in 2020, as I said, more calls and institutions began removing race. And then in 2020, last year, the NKF and the ASN formed a task force because of all the chatter that I talked about. And the task force report was released this past September. So the other thing I wanted to remind you is that race, this removing of race was removal of race in the reporting, but not in the calculations. And so I said in my article last year, the estimation of essential physiologic processes such as kidney function with variables that do not incorporate race and are more accurate than race is a worthy aspiration, but those estimating equation tools should have equal or greater precision, be soundly grounded in evidence on outcomes, and be acceptable to patients. And I outlined a variety of approaches here, and I've really highlighted in orange this practice that was going on of what I call normalizing to the white population by dropping the race coefficient, something I often refer to as ethnic cleansing of the data. So, but the important thing is, what are the potential clinical and health consequences? Does it lead to an increase in persons with CKD in more severe stages? Does that mean in the past we had underdiagnosis or would change overdiagnosis? Well, let's look at the balance sheet. So the benefit that was claimed was that it would increase referral. But if you change this, it would increase referral to specialists, increase access to the wait list to other Medicare services, and might lead to more aggressive CKD management for those for African Americans. That actually affects about 40 to 60,000 Black adults in the United States. If you look at the harms, though, you have to consider that it might lead to less living kidney donation. And I think importantly that it might lead to the less use and dosing of important medications that African Americans have benefited from, and for which there have been disparities in metformin use, disparities in pain medication dosing, as well as chemotherapy dosing, particularly for ovarian cancer in Black women. All those have been documented. And it could lead to decreased contrast imaging procedures, access to clinical trials, and perhaps anxiety or labeling. And the number of Black adults that could be affected is quite large. So this was, let me go over the fix. The NKF task force worked for nearly a year. You can see a diverse group of members, and this was our process to get information and synthesize that information to come up with a unifying approach. So we sought wide range of evidence and views. We had 40 sessions with 97 people from 21 US states and 7 countries. We had community forums that included trainees, providers, and patients. We made a new call for new science that might inform the task force. Importantly, we published in an interim report statements of evidence and value about the things that were confronting us. And this actually helped and was a cornerstone in forging a path forward. And then importantly, we came up with an inventory of different approaches to estimating and reporting kidney function and attributes to be considered in the final recommendation among alternative approaches. These are, in general, the approaches that we use, either using creatinine as a biomarker or not creatinine, such as cystatin C as a biomarker, or the use of racing equations, the use of race in the equations, but without reporting, and then estimation without race in the equation. And finally, at the bottom of the slide, it's important to recognize that any of the above, either in combination or in sequence, could be used by different clinical indications. That is, one of the above approaches followed by another for confirmation. So these were the 6 attributes that we considered: assay availability, implementation by laboratories, performance compared to measured GFR, population diversity in equation derivation, patient-centeredness, and then importantly, the consequences for general medical care, nephrology care, medication dosing, clinical trial eligibility, recruitment, and population tracking. This is the article that was published on September 23rd of this year, describing a new approach. And along this side, this article published in the Society's journals was 2 articles in the New England Journal, for which was new science that the task force had heard about in the earlier months. So this is what we recommended: immediate implementation of the 2021 CKD epicreatinine equation, refit without the race variable in the United States. And you can see the mathematics there. There is no race coefficient. The rationale is it doesn't include race in calculation and reporting. It includes the diversity in its development. It's immediately available to all labs. It has acceptable performance characteristics and has potential consequences, importantly, that do not disproportionately affect one group of individuals. And it's suitable as the first line for the approximately 15% of the people in the United States with chronic kidney disease, but importantly, 85% of people in the United States do not have chronic kidney disease. This shows a Consumer Reports kind of catalog that the task force went through. These 13 of the different approaches showed here, whether it included race, was included in calculation and reporting. And we outlined the challenges across those attributes, minimal in teal up to purple in many. And you can see that the refit equation had minimal challenges across all those different attributes. And this is the crux of it. I want to just show you that this slide shows on the y-axis measured GFR and estimated GFR. The black line is the line of identity. And this is the current equation with race in it. And you can see that for blacks in green and for non-blacks in orange, that the estimation, the average estimation is quite along that black line. But you can also see that the scatter is quite significant. And in fact, the accuracy is not perfect as measured by what we call P30, the percentage estimates within 30% of measured GFR. But look at this, in the middle panel is when you drop the black coefficient and assign the non-black coefficient to black participants. It results in all the bias being concentrated in black participants. And then on the right-hand slide is the new refit equation. And what's interesting about that is that the new equation that's race blind splits the bias evenly across one groups, but leads to one estimate for all people. We also recommended national efforts to facilitate increased routine and timely use of cystatin, especially for confirmation of eGFR. And actually using 2 markers is actually more accurate than using one marker alone. So creatinine cystatin equation, refit without the race variable would be another approach if cystatin were available everywhere. And then we importantly made a call for investment in new science with around eGFR estimation. But I think particularly why this was all started is that interventions to eliminate racial and ethnic disparities. This shows the two other equations, the cystatin strategies. I just wanted to show you this in terms of the difficulties that were there, not perfect, but better than many of the other approaches. So in summary, I've tried to outline the fuss, the fuzziness about race, the fiction, the facts, and the fix about using race in estimating kidney function. There are good reasons to replace race when possible, given the social, political, and biologic conundrum. But making changes is not a trivial task. We want to avoid doing more harm than good. And those consequences differ depending on how race is moved at different GFR levels and different clinical decisions. We reached an actionable consensus recommendation in 1 year. And while it's not a clinical practice guideline, we're hopeful that this solution will allow a consistent, durable, and evidence-based approach to eGFR. And if recommendations are adopted universally, it will be easier to understand GFR change when a patient receives care in different settings and institutions, because what was happening, you could go down the block three blocks away to a different hospital and have kidney disease in one system, but not in another. And that is just chaos. I want to leave you with this, that health equity is the goal. So where should we set our sights and efforts? A lot of our sights and efforts have been set on eGFR equations, but there are a larger set of drivers of these disparities. I know that through the work that I have done over the last 3 decades. And they include biology, environment, behavior, clinical and health policies, and care delivery. And that doesn't mean that, in fact, internalized racism, institutional racism, and personally mediated racism could be involved in that. So let's keep our sights and attention on trying to identify these drivers and put interventions, tailoring interventions to achieve health equity and justice. So I want to thank you for listening. I know that was quite a bit to go over. But thank you for your patience in listening.
Thank you, Dr. Powe. That was a terrific talk, and we look forward to some more discussion when we get into the Q&A session in a little while.